Birth trauma represents a critical category of neonatal injuries that every NICU professional must understand thoroughly. These mechanical injuries occur during the complex process of labor and delivery, creating a spectrum of clinical challenges that range from minor cosmetic concerns to life-threatening emergencies requiring immediate intervention. Understanding birth trauma becomes particularly important when we consider that the true incidence has been significantly underestimated, primarily because many of these injuries appear asymptomatic initially, but may have profound long-term consequences. The delivery process subjects every infant to mechanical forces, but birth trauma occurs when these forces exceed normal physiological limits. Think of delivery as a carefully orchestrated mechanical process where the fetal head must navigate through the maternal birth canal. When this process encounters unusual resistance or acceleration, the delicate balance between protective compression and harmful deformation can be disrupted. In the NICU setting, recognition becomes paramount because early identification allows for prompt intervention that can dramatically alter outcomes. The pathophysiology underlying these injuries helps us understand why certain infants are more vulnerable and guides our clinical decision-making. From subdural hemorrhages requiring immediate surgical evaluation to more subtle injuries that manifest days later, the clinical presentation of birth trauma demands both vigilance and expertise. Our focus on evidence-based management strategies ensures that we can optimize outcomes while providing families with accurate prognostic information during these challenging early hours and days of life. Birth trauma encompasses any mechanical injury sustained during the labor and delivery process, fundamentally resulting from unusual or rapid deforming stresses that exceed the infant's physiological tolerance. To understand this concept clearly, we must recognize that every delivery involves mechanical forces, but birth trauma occurs when these forces become pathological rather than physiological. The mechanisms underlying birth trauma include compression forces as the fetal head passes through the birth canal, molding stresses that normally help accommodation but can become excessive, and extraction-related stresses from instrument-assisted deliveries. Evidence from large epidemiological studies reveals that the incidence varies dramatically based on delivery circumstances. For example, California database analysis of over 600,000 births showed symptomatic intracranial hemorrhage rates of 1 per 1,900 spontaneous deliveries, 1 per 860 vacuum extractions, and 1 per 664 forceps deliveries. However, these figures represent only the tip of the iceberg. Recent prospective studies using MRI in asymptomatic newborns reveal much higher frequencies, with one large study finding an 8% prevalence of subdural hemorrhage in apparently normal infants during the first month of life. This dramatic difference between symptomatic and total incidence underscores a crucial clinical point. Many birth trauma cases remain unrecognized because they present without obvious symptoms. The clinical spectrum truly ranges from minor findings like small subgaleal hemorrhages that resolve spontaneously to devastating injuries like large posterior fossa subdural hemorrhages that can cause brainstem compression, requiring emergency neurosurgical intervention. This wide range means that maintaining clinical suspicion becomes essential for optimal outcomes. The pathophysiology of birth trauma centers on a fundamental mismatch between the mechanical forces of delivery and the infant's ability to withstand those forces safely. Birth trauma occurs most commonly when infants face unusual deforming forces during delivery, creating a perfect storm of mechanical stress that overwhelms normal protective mechanisms. Several key anatomical and physiological factors contribute to this vulnerability. The combination of a large fetal head relative to the maternal birth canal creates the primary mechanical challenge. When we add an unusually compliant fetal skull, which normally provides protection through controlled deformation, to unusually rigid pelvic structures that cannot accommodate easily, we create conditions ripe for injury. The temporal aspects of labor play equally important roles in the pathophysiology. Consider how a short duration of labor prevents adequate pelvic structure dilation, forcing the fetal head through insufficient space. Conversely, unusually prolonged labor subjects the head to sustained compression and molding forces that can exceed physiological limits. Both scenarios create mechanical stress that can result in injury. Compression and molding during passage through the birth canal represent normal physiological processes that become pathological when excessive. The fetal skull's remarkable ability to compress and mold usually protects the brain, but when forces exceed these protective capabilities, injury occurs. Similarly, extraction stresses from instrument-assisted deliveries can create rapid deformation that bypasses the skull's protective mechanisms. Understanding these pathophysiological principles helps us identify high-risk deliveries and anticipate potential complications. Atypical presentations like breech, face, or brow presentations alter normal force distribution, while difficult vacuum extractions, challenging forceps applications, or complex rotational maneuvers can generate forces that exceed physiological tolerance, making birth trauma more likely, and helping guide our clinical vigilance and management strategies. Understanding fetal risk factors for birth trauma requires recognizing how specific fetal characteristics create mechanical challenges during delivery. These factors fundamentally alter the physics of the birth process, increasing the likelihood that normal delivery forces will exceed safe limits. Macrosomia, defined as birth weight above 4,000 grams, represents one of the most significant fetal risk factors. Evidence directly links large infants to increased birth trauma risk because size creates cephalopelvic disproportion, essentially a mechanical mismatch where the fetal head becomes too large relative to the maternal pelvis. Think of this as trying to fit a large object through a smaller opening. The increased force required creates conditions ripe for injury. Cephalopelvic disproportion can occur even in normal weight infants when fetal head size exceeds pelvic capacity. This situation forces delivery to rely on excessive mechanical forces, potentially overwhelming the fetal skull's protective mechanisms. Atypical presentations create entirely different mechanical challenges. Breech presentation, particularly with neck hyperextension, alters normal force distribution during delivery. Instead of the well-designed fetal head leading the way and gradually dilating the birth canal, the body emerges first, leaving the largest part, the head, for last when maternal tissues are already fatigued. Face and brow presentations prevent normal fetal head flexion, presenting larger diameters to navigate the pelvis and increasing the risk of mechanical trauma. Post-term pregnancy compounds these risks through decreased amniotic fluid levels. Oligohydramnios reduces the cushioning effect that normally protects the fetus during contractions and delivery. Without adequate fluid buffering, the fetus experiences more direct compression forces, making birth trauma more likely. This demonstrates how seemingly unrelated factors like amniotic fluid volume can significantly impact delivery safety. Maternal factors contributing to birth trauma center on anatomical and physiological characteristics that affect the delivery process. Understanding these factors helps us anticipate challenging deliveries and prepare for potential complications. Primigravida status, being a first-time mother, significantly increases birth trauma risk. The evidence shows primiparity as a documented risk factor for perinatal complications, including stroke and hemorrhage. This occurs because first-time mothers have less pliable birth canal tissues that haven't been previously stretched by delivery. The cervix, vaginal canal, and pelvic floor muscles are less compliant, requiring greater forces to achieve adequate dilation and stretching. It's analogous to breaking in new leather. The first stretching requires more force and creates more stress on the material. Pelvic abnormalities represent direct mechanical obstacles to safe delivery. Contracted or malformed pelves create fixed anatomical barriers that cannot accommodate normal fetal passage. When we encounter unusually rigid pelvic structures that resist normal dilation, the delivery process must overcome these limitations through increased force, potentially exceeding safe limits for the fetus. Maternal factors affecting labor progression create temporal challenges that compound mechanical risks. When labor fails to progress normally due to maternal factors like inadequate uterine contractions or cervical dystocia, prolonged compression forces can result in fetal injury. Conversely, precipitous labor patterns don't allow sufficient time for gradual tissue accommodation. Previous history of difficult deliveries provides important prognostic information because it often indicates persistent anatomical or physiological challenges. Mothers who've experienced shoulder dystocia, prolonged labor, or required operative delivery may face similar challenges in subsequent pregnancies, particularly with larger infants. This historical information helps clinical teams prepare for potentially complicated deliveries and consider preventive interventions. Labor and delivery factors represent the dynamic mechanical processes where birth trauma most commonly occurs. These factors involve the timing, duration, and method of delivery, each creating specific risks that clinicians must recognize and manage. Prolonged labor subjects the fetal head to extended compression and molding forces beyond normal physiological limits. The evidence clearly documents that unusually long labor, where the head endures prolonged compression and molding, significantly increases birth trauma risk. During extended labor, the fetal skull undergoes continuous deformation that can exceed its protective capacity. Think of this as sustained pressure on a flexible structure. Initially protective, but potentially harmful when prolonged beyond normal limits. Conversely, precipitous labor creates the opposite problem by not allowing gradual adaptation. Rapid delivery doesn't permit the normal, gradual accommodation that protects both mother and infant. The sudden, intense forces required for rapid delivery can overwhelm protective mechanisms that normally have time to engage gradually. Short-duration labor presents a paradoxical risk. While quick might seem better, insufficient time for pelvic structure dilation forces delivery through inadequately prepared passages. This creates excessive resistance that requires dangerous force levels to overcome. Instrument-assisted deliveries dramatically increase birth trauma risk, as evidenced by California database statistics showing intracranial hemorrhage rates of 1 per 860 vacuum extractions and 1 per 664 forceps deliveries, compared to 1 per 1900 spontaneous deliveries. Difficult vacuum extractions, challenging forceps applications, and rotational maneuvers during delivery are specifically documented as high-risk procedures. These instruments, while potentially life-saving, apply direct mechanical forces to delicate fetal structures. Vacuum extraction creates suction forces on the scalp and skull, while forceps deliver direct compression to the fetal head. Rotational maneuvers add torsional stress that can damage blood vessels and neural structures. Understanding these risks helps clinicians make informed decisions about when instrument assistance truly benefits the infant. Several additional risk factors for birth trauma deserve special attention because they often represent systemic conditions or unusual circumstances that significantly compound delivery risks. These factors frequently interact with other risk categories, creating compounded hazards. Coagulation disturbances in either mother or infant create particular vulnerability to hemorrhagic birth trauma. The evidence specifically documents that birth trauma can result from coagulation disturbances, making bleeding more likely and more severe when mechanical injury occurs. When normal hemostatic mechanisms are impaired, even minor vascular trauma during delivery can result in significant hemorrhage. This is particularly concerning for intracranial hemorrhages, where even small bleeds can have devastating consequences. Maternal abuse with blunt force trauma to the abdomen represents a tragic but important risk factor that clinicians must recognize. This mechanism can cause direct fetal injury before delivery and may also alter normal delivery mechanics, increasing the likelihood of birth trauma. Healthcare providers must maintain appropriate suspicion and provide sensitive care when this risk factor is suspected. Multiple gestations create space constraints that fundamentally alter delivery dynamics. Twin or higher-order pregnancies often result in unusual fetal positioning, premature delivery, and complicated extraction procedures. The evidence shows multiple gestation as a documented risk factor for perinatal complications. Space limitations can prevent normal fetal positioning and may require complex delivery maneuvers that increase trauma risk. Oligohydramnios reduces the crucial cushioning effect that amniotic fluid normally provides during labor and delivery. Without adequate fluid buffering, the fetus experiences more direct compression forces from uterine contractions and delivery manipulations. This lack of protective cushioning makes birth trauma more likely. Abnormal fetal positioning during labor encompasses various malpositions that alter normal delivery mechanics. Whether due to intrauterine constraints, fetal anomalies, or random positioning, abnormal fetal positioning often requires corrective maneuvers or alternative delivery approaches that increase mechanical stress and birth trauma risk. Effective birth trauma assessment begins with understanding that many injuries remain initially asymptomatic, requiring systematic vigilance to identify potentially serious conditions before they manifest clinically. The evidence clearly demonstrates that subdural and subarachnoid hemorrhages often occur with no injury to the scalp or head to suggest intracranial injury, meaning hemorrhages may go unrecognized without careful assessment protocols. Systematic examination immediately after delivery forms the foundation of effective birth trauma detection. This comprehensive head-to-toe evaluation must be methodical and thorough because the clinical presentation can be deceptively subtle initially. We begin with overall appearance assessment. Does the infant look sick or distressed? The skin examination reveals crucial information about trauma, looking for pallor, bruising, or petechiae that might indicate underlying injury or coagulation issues. Assessment of neurological status and reflexes requires particular attention to consciousness level, spontaneous movements, and primitive reflexes. The neurological examination should assess the degree of alertness, whether the infant fixes and follows, and the quality of spontaneous movements. We evaluate primitive reflexes systematically, noting any asymmetries or abnormalities that might suggest neurological compromise. Evidence shows that neurological symptoms like altered mental status or seizure activity serve as key indicators for further evaluation. Evaluation of respiratory and cardiovascular stability becomes critical because birth trauma can affect multiple organ systems simultaneously. We assess respiratory rate, pattern, and diaphragmatic movement, looking for signs of distress that might indicate intracranial pressure effects or direct respiratory compromise. Cardiovascular assessment includes heart rate patterns, perfusion, and blood pressure stability, as these can reflect both direct cardiac effects and secondary responses to neurological injury. Documentation of all findings for ongoing monitoring creates the essential foundation for tracking clinical evolution, as symptomatic subdural hemorrhages often present 24 to 48 hours after birth with nonspecific signs including apnea, respiratory distress, altered neurologic state, or seizures. Understanding the distinction between serious findings requiring immediate intervention and benign findings requiring observation represents one of the most critical skills in birth trauma assessment. This differentiation often determines whether an infant receives life-saving treatment or unnecessary invasive procedures, making accurate clinical judgment essential. Serious findings requiring immediate intervention center on signs indicating potential intracranial pathology or systemic compromise. Altered level of consciousness represents perhaps the most concerning finding. As evidence shows, this can indicate significant intracranial hemorrhage or brain injury. When we observe stupor, coma, or markedly decreased responsiveness, these suggest substantial neurological compromise requiring urgent evaluation and intervention. Respiratory distress or apnea demands immediate attention because it can indicate several serious conditions. The evidence documents ataxic respirations, respiratory arrest, and apnea as presenting signs of serious birth trauma. These respiratory changes may reflect direct brainstem injury, increased intracranial pressure affecting respiratory centers, or secondary effects of neurological compromise. Cardiovascular instability, including bradycardia or cardiovascular compromise, requires urgent intervention. The evidence specifically identifies bradycardia as a presenting sign of serious intracranial hemorrhage, often indicating brainstem involvement or increased intracranial pressure affecting vital regulatory centers. Seizure activity represents clear evidence of neurological injury requiring immediate evaluation and treatment. The evidence shows seizures as a common presentation of subarachnoid hemorrhage and other forms of birth trauma, typically indicating cortical or subcortical irritation from blood or injury. Signs of increased intracranial pressure, including nuchal rigidity with retrocollis or opisthotonos, unequal pupils, or abnormal eye movements, suggest serious intracranial pathology requiring neurosurgical evaluation. In contrast, benign findings requiring observation include minor scalp swelling, crossing suture lines, which typically represents Caput Succedaneum that resolves spontaneously, and superficial abrasions or bruising that don't suggest deeper injury. These findings require monitoring but don't indicate immediate threats to neurological integrity. Imaging decisions in birth trauma require understanding both the capabilities and limitations of different modalities, along with clear indications that justify the risks and resources involved. The evidence provides specific guidance about when and how to image infants with suspected birth trauma. MRI represents the preferred modality when available for comprehensive evaluation because it offers superior sensitivity for detecting intracranial injury compared to other modalities. The evidence clearly states that MRI has better sensitivity for detecting parenchymal injury than CT and is more effective than CT in delineating posterior fossa subdural hemorrhage. MRI can detect the vast majority of subdural hematomas, which are often infratentorially located where ultrasound has significant diagnostic challenges. The development of more rapid MRI sequences allows for shorter studies while maintaining diagnostic accuracy, enhancing its practical utility. CT proves useful for rapid diagnosis in unstable patients where time is critical and MRI availability is limited. The evidence supports CT's role when emergency surgical intervention might be needed, as it can be performed quickly after admission. However, given radiation exposure risks, CT should be reserved for specific clinical scenarios rather than routine screening. Cranial ultrasound has significant limitations that clinicians must understand. The evidence clearly documents that ultrasound lacks sensitivity for detecting extracranial hemorrhages and is particularly limited for subdural, subarachnoid, and extradural hemorrhages. Ultrasound also lacks sensitivity in detecting subarachnoid hemorrhage because of normal increased echogenicity around the brain periphery. While ultrasound can detect some hemorrhages, it generally requires imaging through multiple fontanelles and still demonstrates far better lesion extent and distribution with MRI or CT. Lateral skull X-rays maintain utility for identifying skull fractures, providing important information about potential underlying brain injury when fractures are present. The evidence provides specific indications for imaging based on the 2002 American Academy of Neurology practice parameters, which recommend imaging for neonates with birth trauma and low hematocrit or coagulopathy. Additional indications include neurological symptoms or altered mental status, which may indicate significant intracranial pathology, and suspected intracranial hemorrhage based on clinical presentation or risk factors. Successful management of birth trauma requires understanding that these injuries affect not just the immediate medical condition, but the entire trajectory of infant development and family adaptation. The evidence demonstrates that coordinated, multidisciplinary care fundamentally improves outcomes and represents best practice for complex neurological conditions in neonates. Neonatology provides the foundation as the primary management and monitoring specialty, but the evidence clearly shows that follow-up programs must be integral extensions of every neonatal intensive care unit. Neonatologists coordinate immediate care decisions while maintaining longitudinal oversight of the infant's adaptation and development. The initial continuity of care by the neonatologist proves essential for reassuring families that the same personnel responsible for life-saving decisions continue assuming responsibility for the child's transition to home life. This continuity builds trust and ensures seamless communication as the clinical picture evolves. Neurosurgery becomes critically important when the evidence indicates need for intervention. The project knowledge documents that rapid surgical evacuation may be required for severe life-threatening hemorrhages, while less severe cases may need neurosurgical drainage for increased intracranial pressure or mass effect. Neurosurgical evaluation provides expert assessment of when surgical intervention benefits the infant versus when conservative management suffices. This expertise proves invaluable because the evidence shows that most neonates with subdural hemorrhage can be managed conservatively, but knowing when surgical intervention becomes necessary can be life-saving. Radiology contributes specialized expertise in appropriate imaging interpretation that directly impacts clinical decision-making. The evidence demonstrates that different imaging modalities have distinct sensitivities and limitations, making radiological expertise essential for accurate diagnosis and monitoring. Understanding when MRI provides superior information versus when CT offers adequate rapid diagnosis requires specialized knowledge that directly influences treatment decisions and family counseling. Nursing provides the continuous bedside assessment and family education that forms the backbone of effective care. The evidence emphasizes that serial monitoring of hematocrits, vital signs, head circumference measurements, and neurological status requires skilled nursing observation. Nurses also serve as primary educators for families, helping them understand the condition, recognize concerning changes, and participate effectively in their infant's care. Social services addresses the significant family stress and support needs that the evidence clearly documents. Parents experience varying degrees of stress when facing neonatal complications, and this stress increases as families progress through diagnosis and treatment phases. Social services helps identify resources, coordinate discharge planning, and connect families with community support systems. The evidence shows that greater family resources provide protection against persistent stress, making social service support essential for optimal family adaptation. Physical therapy provides crucial long-term developmental support based on evidence showing that infants at highest risk for neurodevelopmental problems include those with severe neurological injuries. Early intervention services beginning in infancy and continuing through childhood significantly improve functional outcomes. The evidence demonstrates that early developmental intervention programs improve school-age functional outcomes among NICU graduates, making physical therapy an essential component of comprehensive care. This multidisciplinary approach recognizes that birth trauma affects the entire family system and requires coordinated expertise from multiple specialties working together toward optimal long-term outcomes. Extracranial hemorrhages require precise knowledge of scalp anatomy to differentiate between conditions with vastly different clinical implications. The scalp consists of 5 distinct anatomical layers, easily remembered through the mnemonic scalp, where each letter corresponds to a specific structural component from superficial to deep. The skin forms the outermost layer, followed by the connective tissue containing subcutaneous fat and vascular networks. The aponeurosis, commonly termed the galea, consists of dense fibrous tissue that forms a continuous sheet across the cranium. Below this lies the loose connective tissue layer, which contains areolar tissue and emissary veins. The periosteum represents the deepest layer, adhering directly to the skull bones. Each extracranial hemorrhage occurs within a specific anatomical compartment. Caput succedaneum develops within the connective tissue layer, producing edematous swelling that crosses suture lines. Subgaleal hematoma accumulates in the loose connective tissue space between the galea and periosteum, creating a potential space capable of containing significant blood volumes. Cephalohematoma forms beneath the periosteum, remaining confined by suture line boundaries due to periosteal attachments. The anatomical location determines clinical behavior and risk stratification. Collections in superficial layers typically remain limited and resolve spontaneously. Bleeding in deeper spaces, particularly the subgaleal compartment, can accommodate volumes approaching total neonatal blood volume, creating life-threatening hemorrhagic complications. The relationship to anatomical boundaries, such as suture lines, provides immediate diagnostic differentiation and guides appropriate clinical monitoring protocols. These conditions most commonly follow prolonged labor, instrumental deliveries, or significant birth trauma. The mechanical forces involved in these delivery scenarios can disrupt vessels within specific anatomical planes, producing the characteristic bleeding patterns that define each condition. Understanding Caput succedaneum requires grasping how mechanical forces during delivery affect scalp anatomy. Think of the scalp as having distinct layers. When the fetal head presses against maternal tissues during labor, venous return from the superficial layers becomes compromised. The mechanism centers on hydrostatic pressure changes. As the presenting part encounters resistance, blood flow out of the area slows while arterial inflow continues, creating a pressure differential. This forces fluid from capillaries into the loose subcutaneous tissue above the skull's periosteal covering. What makes this clinically significant is the anatomical relationship between periosteum and suture lines. The periosteum adheres tightly to each individual skull bone, but doesn't bridge across sutures. This means fluid accumulating above this membrane can spread freely across these anatomical boundaries, creating the classic presentation that distinguishes caput from deeper collections. This pathophysiology explains why caput develops during prolonged labors with vertex presentations and why it's the most common birth-related scalp finding. The mechanical stress-response relationship directly correlates with the clinical findings you'll observe. When examining these infants, you're feeling the physical manifestation of that fluid extravasation we just discussed. The soft, doughy texture reflects serum in loose subcutaneous tissue, quite different from blood under pressure or deeper fluid collections. The pitting quality occurs because you're compressing fluid in tissues with good compliance. When you apply gentle pressure, fluid temporarily displaces, creating the characteristic indentation that slowly refills. This physical finding immediately tells you the location and nature of the accumulated material. The boundary crossing pattern provides the definitive diagnostic information. Since the fluid sits above the periosteum, it flows around the skull's contours unrestricted by suture attachments. This creates swelling that extends beyond what you'd expect from a single bone's surface area. The timing, present at birth, reflects the acute nature of the delivery process that created it. Unlike conditions that develop postnatally, this represents the immediate consequence of birth mechanics. The management philosophy stems directly from understanding the pathophysiology. Since this represents fluid in highly vascular tissue with excellent lymphatic drainage, natural reabsorption occurs rapidly once delivery pressures are relieved. Your role focuses on parent education rather than medical intervention. Families need to understand that despite the concerning appearance, this represents a normal response to birth mechanics rather than pathology requiring treatment. The key teaching point is the predictable resolution timeline. The excellent prognosis reflects the superficial location and the body's efficient mechanisms for clearing extravascular fluid. Unlike deeper collections that may persist for weeks, the subcutaneous location allows rapid restoration of normal tissue architecture. The management philosophy stems directly from understanding the pathophysiology. Since this represents fluid in highly vascular tissue with excellent lymphatic drainage, natural reabsorption occurs rapidly once delivery pressures are relieved. Your role focuses on parent education rather than medical intervention. Families need to understand that despite the concerning appearance, this represents a normal response to birth mechanics rather than pathology requiring treatment. The key teaching point is the predictable resolution timeline. The excellent prognosis reflects the superficial location and the body's efficient mechanisms for clearing extravascular fluid. Unlike deeper collections that may persist for weeks, the subcutaneous location allows rapid restoration of normal tissue architecture. When you examine these infants, you're feeling the physical consequences of bleeding under pressure in a confined space. The firm, non-pitting quality immediately distinguishes this from Caput Succedaneum. You're palpating clotted blood and serum contained by the tough periosteal membrane rather than loose fluid in subcutaneous tissue. The timing provides crucial diagnostic information. Unlike Caput Succedaneum's immediate presentation, cephallohematomas develop over hours as bleeding accumulates to clinically detectable levels. This delayed appearance often concerns parents who notice the swelling increasing after birth. The boundary pattern offers definitive diagnosis. The strict confinement by suture lines reflects the subperiosteal location. Blood cannot cross these boundaries because periosteum doesn't bridge across sutures. When you palpate carefully, you can often feel the sharp demarcation at suture edges. The fluctuant quality that develops as the hematoma matures reflects the liquid component of partially clotted blood. This can create confusion with other conditions, but the anatomical boundaries and timing help differentiate cephalohematoma from other scalp collections. Understanding complications requires recognizing that cephalohematoma represents significant blood loss in a space with limited reabsorption capacity. This creates predictable problems requiring systematic monitoring. Hyperbilirubinemia is the most frequent complication. As red blood cells within the hematoma break down over days to weeks, they release substantial bilirubin into circulation. This process often coincides with physiologic jaundice, potentially compounding the problem. Large hematomas can contribute enough bilirubin to necessitate phototherapy or even exchange transfusion. The timing typically peaks around days 3 to 5, requiring close monitoring during this critical period. Skull fractures accompany a small percentage of cases. The same traumatic forces causing vessel rupture can crack underlying bone. These are typically linear fractures beneath the hematoma that heal spontaneously but require documentation. The presence of fractures doesn't change immediate management, but may influence monitoring intensity. Anemia develops with large hematomas, particularly problematic in smaller infants, where blood loss represents a more significant percentage of total blood volume. Serial hematocrit measurements help identify clinically significant bleeding requiring intervention. Infection, while rare, carries serious consequences. Accumulated blood provides excellent bacterial growth medium, especially if any communication with external environment exists. Watch for local signs like increasing warmth and erythema, or systemic signs suggesting sepsis. Calcification occurs when reabsorption is incomplete, typically with larger lesions. This leaves behind palpable calcified deposits that can persist for months, creating lasting cosmetic concerns requiring family counseling. Management centers on conservative observation while systematically monitoring for complications. The fundamental principle is avoiding aspiration or drainage, which dramatically increases infection risk without providing meaningful benefit for resolution. Your monitoring protocol should include serial hematocrit measurements to detect significant blood loss, particularly important in smaller infants. Begin bilirubin level tracking around day 3 to 4 when breakdown products peak, continuing based on clinical appearance and risk factors. Assessment for underlying skull fractures involves careful palpation and potentially imaging when clinical suspicion is high, though most linear fractures heal spontaneously. The resolution timeline extends far beyond Caput Succedaneum. Expect 2 to 4 weeks for smaller lesions and up to 3 months for larger ones. This prolonged course reflects the body's need to reabsorb significant amounts of clotted blood through normal physiologic processes. The subperiosteal location, while confining the blood, also limits vascular access needed for rapid reabsorption. Parent education is crucial given the extended timeline and potential for temporary size increase before resolution begins. Families need realistic expectations about the prolonged process and clear guidance about warning signs requiring immediate attention. Long-term prognosis remains excellent when uncomplicated, with complete resolution expected in the vast majority of cases. To understand subgaleal hematoma, we need to carefully examine the scalp's anatomical layers, because this condition occurs in a space that makes it uniquely dangerous. The scalp has multiple layers, and the subaponeurotic space where this bleeding occurs sits between the galea aponeurotica and the periosteum. Think of the galea aponeurotica as a tough, fibrous sheet that covers the top of the skull like a cap. Below this lies the subaponeurotic space, which under normal circumstances is just a potential space containing loose connective tissue. However, this space has a crucial anatomical feature that distinguishes it from the spaces we've discussed in Caput Succedaneum and Cephalohematoma. The key difference is that this space is enormous. This potential space extends from the orbital ridges anteriorly all the way to the nape of the neck posteriorly and laterally from ear to ear. When bleeding occurs here, blood can spread throughout this entire area because there are no anatomical barriers to contain it. This represents a fundamentally different situation from a cephalohematoma, which remains confined by suture lines, or Caput Succedaneum, which involves superficial fluid collection. The clinical significance becomes clear when you realize this space can hold up to 260 milliliters of blood, representing approximately 80 to 90% of a newborn's total blood volume. To put this in perspective, a typical term newborn has roughly 280 to 320 milliliters of circulating blood. This means that losing even half of this space's capacity represents catastrophic blood loss. This massive capacity explains why subgaleal hematoma ranks as the most dangerous form of extracranial hemorrhage. No other scalp injury can sequester such a large percentage of an infant's blood volume. The strong association with vacuum deliveries occurs because the vacuum cup creates significant negative pressure that can tear vessels in this space. The emissary veins, which are small vessels that connect the scalp circulation to the deeper dural sinuses, become particularly vulnerable during vacuum extraction. When the vacuum seal is broken, or when there's excessive traction, the mechanical forces can rupture these delicate vessels. This leads to bleeding that has an enormous space to expand into, with potentially fatal consequences. Subgaleal hematoma carries a 22% mortality rate when unrecognized, making early identification critical for survival. The key distinguishing feature is its anatomical distribution. Unlike cephalohematoma, which remains confined by suture lines, subgaleal hematoma crosses all boundaries. The bleeding occurs between the skull's periosteum and galea aponeurosis, creating a vast potential space extending from the forehead to the neck and out to the ears. Watch for the characteristic extension pattern, swelling behind the ears into the temporal region, and periorbital ecchymosis, creating raccoon eyes. This occurs because the subaponeurotic space continues laterally to the temporal fascia and anteriorly to the orbital margins. The swelling feels boggy and fluctuant, like a water balloon, distinguishing it from firmer scalp injuries. The physiological danger stems from this space's capacity to hold 260 milliliters of blood, approximately 80 to 90% of a newborn's total blood volume. As blood accumulates from ruptured emissary veins, infants develop progressive signs of hypovolemic shock. Clinical progression follows a predictable pattern. Pallor develops as blood becomes sequestered rather than circulating. Tachycardia represents compensatory attempts to maintain cardiac output with decreased blood volume. Hypotension signals decompensated shock when compensation fails. Decreased urine output reflects renal conservation mechanisms. The temporal pattern creates danger. Unlike other scalp injuries apparent at birth, subgaleal hematoma progresses over 12 to 72 hours. An initially stable infant can rapidly deteriorate as bleeding continues into this vast space, making continuous monitoring essential after instrumental deliveries. Managing subgaleal hematoma demands recognizing that you're facing a medical emergency where rapid intervention determines survival. The potential for exsanguination requires aggressive, systematic management from the moment of diagnosis. Your monitoring protocol must be intensive and frequent. Hematocrit measurements every 4 to 6 hours initially provide objective evidence of ongoing blood loss, but laboratory values alone don't tell the complete story. Serial head circumference measurements offer a practical bedside tool for tracking accumulation. Increases of even 1 to 2 centimeters can represent significant blood loss in this space. Volume resuscitation forms the cornerstone of management, requiring careful consideration of what you're replacing. These infants are losing whole blood, not plasma alone, so your resuscitation strategy should include both crystalloids for immediate volume expansion and blood products to address the loss of oxygen-carrying capacity. Type and crossmatch should be obtained immediately, with blood readily available for transfusion. Avoid the temptation to aspirate or drain the collection. Needle aspiration of subgaleal hematoma introduces significant infection risk without providing meaningful benefit. The bleeding typically originates from multiple small vessels throughout the space, not a single large vessel that drainage could address. Intensive monitoring in a NICU setting becomes essential. These infants require continuous cardiorespiratory monitoring, frequent vital signs assessment, and close observation for signs of ongoing bleeding or hemodynamic compromise. The nursing staff must understand the potential for rapid deterioration and maintain clear protocols for escalating care when clinical status changes. The management approach centers on supporting the infant through the acute bleeding phase, while the body's natural hemostatic mechanisms work to control the hemorrhage. With appropriate volume support and intensive monitoring, most infants can be stabilized successfully. Understanding outcomes and prevention in subgaleal hematoma demonstrates how timing and recognition directly affect clinical results. Early recognition and systematic management can transform what appears to be a devastating hemorrhage into a condition with favorable long-term outcomes for most infants. Prevention centers on understanding that most subgaleal hematomas result from mechanical trauma during vacuum-assisted deliveries. Consider the physics involved. When we apply vacuum pressure to the fetal scalp, we create negative pressure that can exceed the tensile strength of delicate vessels traversing the subaponeurotic space. Prevention strategies must therefore focus on careful technique and appropriate case selection. Proper candidate selection for vacuum delivery requires assessing multiple factors that increase risk. Large infants present particular challenges because the mechanical forces required for extraction are proportionally greater. prolonged second-stage labor suggests that natural delivery mechanisms may be compromised, making instrumental assistance more traumatic. Unusual fetal presentations like occiput posterior can require rotational maneuvers that dramatically increase the mechanical stress on scalp tissues. When vacuum assistance becomes necessary, technique becomes critical. Current evidence supports limiting total application time to 20 to 30 minutes and avoiding excessive negative pressure settings. Perhaps most importantly, we must recognize when vacuum attempts are failing and convert to alternative delivery methods before escalating trauma occurs. 3 pulls without descent or cup detachment more than twice should prompt immediate reconsideration of the delivery approach. Early recognition directly correlates with survival rates. Infants who receive prompt diagnosis and aggressive volume resuscitation typically recover completely with normal neurodevelopmental outcomes. This recovery potential exists because subgaleal hematoma, despite its dramatic presentation, rarely causes direct brain injury. The primary threat comes from blood loss and hypovolemic shock, both of which respond well to appropriate medical management. Family education during recovery helps parents understand that while the acute phase requires intensive monitoring, the long-term prognosis remains excellent when proper management occurs. Parents need practical guidance about monitoring their infant's color, feeding patterns, and activity levels, while understanding which changes require immediate medical attention. This education provides families with both the knowledge and confidence needed during the recovery period.